He's a professor of ophthalmology in Amrita Institute, and he's doing mainly cornea, keratoplasty, eyeball, LASIK, etc. So there's a lot of publication and presentation. Over to Dr. Anil.
Thank you, COC, again for the opportunity. So, eye is a bright reflective cornea, is a sign of health, and this parameter, this particular quality is used in topography. It's just that the eye acts as a mirror. It's a convex mirror which reflects the light, and this has been known since 1854. And video keratography or topography is an extension of that, which came up in 1984. So in topography or video keratoscopy, you project these mice onto the cornea and see this location of the central, in relation to the central fixation point. You look at the points all across these different mice which are mirrored on the cornea, and basically you get a digitized information, and this curvature data comes as a color printout like this. So in any topography, I think you should look at the K values, K1 and K2, which tell, like if it is more than say 47.5, it should raise a red flag. There are other indicators like SRI and SAI. In the newer topography machines, things are different. But these are informative, it gives an information regarding the regularity of the cornea. But it's important, it's very imperative that you get a good tear film, because whatever imaging you do, that is through the tear film, which is the coating the cornea. So if you have a bad tear film, you can get abnormalities like this. There are a variety of normal corneal topographic patterns: round, oval, superior steep. I'll just skip through a few ones. In the left side that you see is a round pattern, and the right side that you see is an oval breaking into a symmetric bow tie pattern. So this is a superior steep pattern. These are all perfectly normal variants of the cornea, and this is not keratoconus at all. So in such a scenario, where if you want to see whether it is normal or not, you have to look at the points at two inferior, superior. That point should be seen around 3 millimeter from the central fixation point. You should see the topographic value. Keep the cursor over there on top as well as bottom, and if the difference is more than say 1.8, it is a red flag. So astigmatism looks something like this: a symmetric bow tie pattern with the rule against the rule. It can be an oblique astigmatism as well. This is my own topography picture. I don't have keratoconus. This is a symmetric bow tie pattern suggestive of a astigmatism. So both the bows of the tie would be symmetric, and these points would be corresponding. That is the important thing. So this is what I am keeping on saying: IS value, that is around 3 millimeter from the cornea. If there is a disparity of more than 1.8 between these two values, it is suggestive of a bad cornea or a keratoconus. So keratoconus has certain features like a steep cornea. It tends to be inferior. I think I'll go through the examples. So this is a patient with an asymmetric bow tie pattern. In contrast to the other one which was symmetric, this is an asymmetric bow tie pattern. And both the bows of the tie will be, normally in a normal cornea it will be in one line, but there will be something called a skewing of the radial axis. There is some, the angle will be much more. If it is up to 10-12 degrees, it is okay, but if it crosses 20 degrees, it is definitely pathological. So this is an example of a patient with an asymmetric bow tie pattern, more prominent in the left eye. This is much more franker keratoconus, in which there is a lot of central steepening. If you look at the steep K, it is 54.69. So if you have a high value like that, it is an abnormal cornea, and most likely it is keratoconus. But if you have a localized steepening like this, it may be something else. So just go back to your ring images, ask the patient to blink a few times, repeat the picture, and then you get a normal image. So that is suggestive. Whenever you have a dry eye, a focal dry spot can throw up red points like that. So we have come a long way from topography in 1984 to now tomography. So tomography, first tomography came in late 90s as OBSCAN, which was elevation-based data. So it made such a big hue and cry at that time. The difference in tomography is that you get the thickness of the cornea and also the posterior curvature of the cornea. So as Dr. Holliday was mentioning, in corneal ectasia, the eyelid moves over the cornea multiple times, almost 18 hours a day. And so the epithelium is very much thin over that area. The epithelial thickness will come down from normal 7 or 8 to 3 or 4 layers. So a lot of these abnormalities in the cornea may be masked by the epithelial remodeling. So that information can be taken from the posterior curvature, which there is no compensation for the posterior curvature. So that is picked up in tomography. That is one great advantage. There are various machines that are available. One is the prototype was the OBSCAN. Then nowadays this is the Scheimpflug devices which are having the top position, of which Pentacam is the most popular one. Sirius and Galilei and TMS5 also uses Scheimpflug imaging, and Sirius has the advantage of using a plasto disc which is more sensitive along with the Scheimpflug imaging, which is quite able to pick up the posterior curvature and other data. So that way there is some advantage for the Galilei as well as Sirius. And in the last 4-5 years, OCT based devices have come up really well, and of which anterior is the most prominent one. We had something called the Visante Omni by Carl Zeiss, which was there about 10 years ago, but unfortunately because of the poor market dynamics, the company stopped production about 4 or 5 years ago. So in all these tomography, you look at something called the best fit sphere. So you try to make a curvature is made based on the data which is there on the cornea. So based on the corneal curvature, you make an average corneal curvature, and then which all areas project above it and below it is what is seen in a best fit sphere. So this is something like this. So in this the green colored dome that you see is the float or the best fit sphere. The cornea is usually prolate shape. So in the central part of the cornea, it will be elevated above that, so it will appear as red color. While in the mid periphery, it will be flat, so it will be appearing as blue in color, and the extreme periphery, the shades of red will again. So among the different tomography machines, what is most prominent nowadays is this Scheimpflug imaging, which is used in Pentacam, Sirius, and Galilei. That uses the Scheimpflug image. If you look at these 3 images, in the first image you see that the rocks are well seen, while the beach sand and the small rocks that you see, small pebbles are not in focus. While if you focus on the small pebbles, the distant images, it does not come into focus. So you use the Scheimpflug principle in which you tilt the plane of the lens so that it is along the curvature of the particular image and interest. For example, in the cornea, you keep it like rotating lens will produce, using the Scheimpflug image, it will provide a good image of the cornea as well as the other anterior segment structures. So it gathers about 25,000 data points, and it gives a chord map, something which looks something like this. So firstly, we need to look at the data K1, K2, astigmatism, the K max, that is the maximum keratometry value, and then you look at the 4 maps. One is the first one that you see is this one that you see is just like any topography machine, the anterior curvature map. Then you have the anterior float, then you have the posterior float as well as the corneal thickness map. This is very useful in refractive surgery. I think I'll not go into those details. And there is another concept called the enhanced best fit sphere, in which basically you have a best fit sphere and you ignore that in the cone which is projecting out and which will abnormally change your this best fit sphere is taken out, and then you see the cone in relation to the best fit sphere. So the small cones can really be projected and it can be very well seen. For example, this is the right side shows the best fit sphere, and this is the second one, is the red one is the enhanced best fit sphere. So that gives a lot of information regarding, especially people who are not very much used to Pentacam. It will immediately tell that there is a problem there. So among the different Scheimpflug imaging systems, the Pentacam scores because of this particular thing called the Billin-Ambrosia enhanced ectasia display. This is looking at data from a lot of people all over the world. So there are 5 parameters. One is the anterior curvature, then the posterior curvature, then the thickness, then the rate of change of the corneal curvature, and the enhancement of the cone. There are 5 parameters they look into, and finally they gave me something called a D value. So a D value of something like more than 2 is definitely dangerous. Anything more than 1.6 should be looked with suspicion. So if you look at a topography like this you know it's an asymmetric bow tie pattern. There is a skewing, and if you look at the values, it is more than 48.7. So you know that it's keratoconus. You don't need any other thing to see whether it is keratoconus. But other findings are corroborating. If you look at the anti-elevation map, this is more than 20, 22. The corneal thickness map, it is coming to 480 or so. Posterior curvature map, again corresponding to that. Everything reaffirming the diagnosis of keratoconus. While in this patient, you see that this is a perfectly normal topography map. The pachymetry map is also perfectly normal. It's actually 590. It's on the thicker side. But if you look at the anterior elevation map, there is some disparity. It's about +7. It is plus or minus. While the posterior curvature map shows a significant difference, about 23. So you need to look at the other parameters, especially the bad criteria and all that. And if the D value is very high, it is not a good candidate for refractive surgery. There are other machines also available. I think this is one of the Visante Omni images which I have been using for more than 12 years. So this gives similar information. Instead of quad map, it has 6 maps. 1 minute more, okay. So this also gives anterior float as well as the posterior float along with the axial curvature maps. Something similar in OBSCAN also. But there is one problem with OBSCAN. This is a patient who had done a LASIK, and after 1 week you look at the OBSCAN, it is so abnormal. It's not because of anything else. There is no posterior curvature that has happened. It's the problem with the imaging. So you should understand that OBSCAN had its days, like sternometry, and it's not a very good device at this point of time. So this is a patient with this pellucid marginal degeneration, in which you see a localized elevation in the lower part. This is a patient who was seen to have a very high K values, and the corneal thickness by OBSCAN was 329. So the patient came for a second opinion whether anything more can be done. So we did a OCT based thing. We did a pachymetry using ultrasound pachymetry and found that the patient has got a thickness of more than 400 microns. And in this also we found that it is more than 400 microns. So the patient was able to undergo C3R. So I would like to conclude saying that topography is a very valuable tool, and it is very important